So let's say your patient has come in and they have been diagnosed with acute renal failure, and they're on your unit and you're caring for them. What is it that you need to worry about? So number one, our goal here as a healthcare team is to get the patient to restore full function of the kidney. In acute kidney injury, that is possible, okay? Again, we're not talking about chronic kidney disease. We're talking about something that has happened very quickly, has caused a sudden onset of kidney failure, or kidney, just the kidneys are not working. It is reversible, okay? So that's our goal. The first thing they're going to do is, or what the underlying thing that we want to do is treat the cause. So what is it that's caused this problem to the kidney? Is it that the patient is extremely hypovolemic, or they have low blood volume? Is it a crush injury? Has their damage been done to the kidney? Is it a nephrotoxic agent? Are they on some kind of antibiotics that you're very sensitive to, and it's causing that damage to the kidneys? Whatever it is, we want to deal with that, because we can treat the kidney failure as long as we want. Well, not as long. Someone will eventually die, but if for example, it's caused by an infection, strep infection is a big thing that causes glomerulonephritis. If we don't treat that, it doesn't matter how much we treat the symptoms, it's eventually going to kill the patient, unless the body is very, very strong and can fight that off on its own, right? So we got to treat the underlying cause. Fluid restriction is a big thing in kidney disease. Think very, very similar to CHF. If the kidneys are not filtering fluid properly, if they're not concentrating urine, it's not being excreted in the urine, where's that fluid going? Well, it's backing up into the body, into the interstitial spaces, and can cause all kinds of problems, including hypertension, edema, the things we talked about in the other videos. So the rule for acute kidney injury is we allow 600 milliliters and then per day, and then on top of that, however much they've lost in the previous 24 hours. So you can lose fluid in a number of ways, right? It's not just through urinating. It's through sweating, diarrhea, throwing up, or emesis. And so in a perfect world, you're able to track all of that, and however many milliliters that all adds up to, you add 600 milliliters for that, and that's how much the patient is allowed to have during the day. Yeah, and in terms of nutrition, we'll talk about this a little bit more later, but protein is really, really important because of the way the protein, the role it plays in fluid balance, and the role it plays in kidney function, and in and so I just don't want to go too far into things. Having adequate protein intake, but not too much intake, too much protein. So protein needs to really be balanced. And then we do sodium, potassium, and phosphate restriction. Sodium restriction, simple, because water follows sodium. If we haven't learned that in patho by this point, hopefully you did. Hopefully that's been hammered into your head during your electrolyte balance courses, but water follows sodium, so we're going to keep the sodium down because we don't want more fluid in the body. The potassium, again, it's already building up in the blood system. We don't need more of it. The kidneys are not filtering it out, and higher your potassium goes, it can cause really, really, really big problems for muscle contraction, and especially for the heart rhythm, for the depolarization and repolarization of or electrical impulses in the heart. Okay, phosphate, again, we're going to restrict that because of the relationship between the calcium, the vitamin D, and we will talk, I'm going to do a whole video on potassium, phosphate, calcium later on, so you can look at that. We'll go into it in a little more detail. So again, if the potassium is elevated, we want to lower it. In that other video, I'll go through how we do that. We want calcium supplements. So we literally give vitamin D and calcium. And then phosphate binding, because we need less phosphate. Okay. Again, I'll go into it in the other video a little bit more. Parental nutrition. We need to keep the patient, oftentimes they're not eating. So we need to make sure that they are, and then, or that they have nutrients, sorry. And then possibly we might initiate a renal replacement therapy if that's necessary. And I will talk about that again. There's a whole video on that as well. Let's see what else we have for collaborative care. So as the nurse, it's your job to monitor vital signs depending on what stage the patient is in this AKI. You're going to do that you could do it every 5 minutes, every 15 minutes, and so on. I've had patients where we literally check vital signs every 5 minutes, and some you check once a shift. In this case, you would at least do this every few hours. You're going to monitor intake and output. That's because of the relationship between the fluid balance and your kidneys. You're going to assess the urine. It's really, really important to know how much urine, how often, what color it is, if there's any sediment in it. The specific gravity, glucose, and protein are very important. And blood, we've talked about this in previous videos, so I'm not going to go into it too much. And then the rest of this is your basic assessment, okay? So you're looking at, take it from a head to toe, right? So here they talk about, they talk about LOC here. I literally, when I do a head to toe, I literally go head to toe. I will skip systems that are unnecessary, but for the purposes of this class, it's good to actually go head to toe. So you want to know, is there any change in their level of consciousness, GCS, right? General appearance, what does their skin look like? Are they perfusing well, right? Is there enough blood getting to the distal portions of their body? Listen to their lungs for crackles, wheezes, diminished breath sounds. Why would you have crackles? Well, if you have pulmonary edema from all of the fluid that has backed up, you will have crackles. There'll be coarse crackles. So really common sound that you hear in Emerge for sure. I don't know about a lot of other, you hear it on other units as well. In terms of the cardiac system, really the biggest thing you're worried about are Ecg changes. And that's because of that hyperkalemia or the extra potassium. I don't know that you need to understand the patho behind all of these things and their relation to kidney disease. I can't imagine those coming up. I've literally never had a question about having to understand what's the underlying cause of a gallop or a S3 or what have you. Murmurs I've had to know, pericardial friction rub, but those are all related to the cardiac system and not kidney. So, and the other thing that's really, really important is your lab values. You're going to do blood work at least once a day if your patient is on a unit, and you want to see if always their electrolytes, potassium, creatinine, BUN are the most important. So there are meds as well, and I'll go through that. There's a whole other thing I'm going to do on meds, and we'll talk through them all. But for now, that's it. And we'll move on to chronic kidney disease next.